That's fun.
Okay, let's get started. And it gives me great pleasure to introduce our today's speaker, Dr. Rajesh Mangrulkar. He is Margaret S. Rowe Professor of Medical Education and Associate Dean for Medical Student Education at the University of Michigan. He's also Associate Professor of Internal Medicine and Learning Health Sciences. And Dr. Mangrulkar has been actually very active in educational leadership. He was an assistant residency director of internal medicine. Then he was the director of Encore, which is an educational innovation unit at the dean's office. Then he worked as assistant dean for medical education, and he has been associate dean for medical education at since 2011. He, as an associate dean, has been leading the curriculum, student affairs and admission units for the medical school, and he's been leading the medical school-wide initiative to transform the curriculum. And the reason we invited him, and he's going to talk a lot about this to us. He actually, which is very interesting, that he received a $6 million grant to develop university's first center for interprofessional education, which I did not know. And he also has a 5-year, $1.1 million grant from AMA for his curricular change. So he's been well funded for his medical education and curricular change reform. And now a small tidbit, and then I'll let Dr. Mangrulkar talk, that I did not know, but Dr. Mangrulkar also has a Chicago connection, that he did his MHPE at the University of Illinois in 2001. So, Dr. Mangrulkar.
Great, thank you, Nutan. Thank you all for inviting me. I'm really pleased to be here in Chicago. Chicago is such a nice short trip for me from Ann Arbor, even though many people don't know that we are in the Eastern time zone, not the Central time zone. So have to change my clock a little bit. But other than that, it's a great trip, and we always consider Chicago our second home. So thank you. I'm also happy to share our journey with you, and I will emphasize that it is a journey. We're still very early in this process, and you will hear me make some statements, but I will tell you that the caveat is that we don't necessarily know the full impact of everything that we're doing yet, because we're really on the early curve of our curricular transformation. But I'm really fascinated by everyone's curricular journey. I know you all are on this journey as well, and I think all of our schools that are doing this, it's a really exciting time to be in medical education, because so many schools are transforming. I think the stats are somewhere upwards of 80 to 85% are changing their curriculum. We're all doing it differently, which I think is great, because we all are different schools, but I think we share similar values. And that's where I think the sharing can be very informative. And I also detect a different culture of sharing of everyone's journey now than in previous iterations of curricular transformation. People are much more willing to open up their journey, warts and all. So I will share with you some warts and hopefully some successes as well. And I look forward to engaging with you during the course of the hour today. So I have a couple of disclosures. First of all, the first thing is that this story is really on behalf of a very large team. We have over 300 faculty, staff, and students working on this, really, since the journey began. And also, our leadership, our senior leadership, has been extraordinarily important for us to get to the stage that we're at right now. Dr. Williscroft, Jim Williscroft, who up until recently was our dean of the medical school, and then Senior Associate Dean Joe Kolars, both have been exemplary in helping us get to the place that we're at right now. Finally, as Nutan implied, this story has been partially supported by a grant from the AMA, the Accelerating Change in Medical Education, and Sally Santon is my co-PI on this grant. So the story is fairly complex, and I'm going to talk about some successes and challenges as I mentioned. The story is incomplete, as I mentioned as well. We're in the early part of this journey, but it all has kind of the good elements of a good journalistic piece, for those of you that love journalism, the 5 W's and H's. And I'm going to focus on 3, the why, the what, and the how. And I'm going to answer these questions simultaneously as I paint this story. why did we start on this journey? I think that was a really important question for us to ask ourselves and to communicate to our community, and to do it in a consistent way so that everyone understood the rationale behind the change. We're a pretty good public university. Most people in our community didn't feel like there was a burning platform, and so they really needed to understand why we thought we needed to evolve. The second is, what are really the essential ingredients of our curricular transformation? I'll try to describe them in high level and in some detail as well for those of you that are interested. And then, how have we organized our approach to curricular transformation in order to be able to maximize engagement and our success? We've had the luxury of time to do this. We started this journey, honestly, in 2010, and it's probably not going to be done until 2021. And so with that luxury of time, what we've hoped to do is create a parade of people who are passionate about this, that will join us and allow this to be more of a movement rather than a change in the curricular structure. And then I'm going to describe some of the challenges ahead as well, which I hope will be helpful to you as you're embarking on your own journey. So as we think about why change, I always think about Darwin, who has really been sort of the proponent of observation of how things change. And he said, it's not the strongest of the species that survives, nor the most intelligent, but rather the one most responsive to change. And I would make the argument that medical education has not really been responsive or adaptive to the pressures that have been happening really over the last 20, if not 50 years in clinical practice, in science. We've just adopted the same structure and tried to pack it all in without really adapting to the way forward. On the other hand, change, when the winds of change blow hard enough, even small things can become deadly projectiles. And those of you who have ever tried to embark on major change probably have bruises or fractures that are a result of that movement. I certainly have, and I came into this process bruised, as I will explain. But I think that bruising helped us think about what is the right pace of change moving forward as we go on this journey. So as schools across the country are really wrestling with these issues and are trying to really determine the way forward, what we decided to do was deliberately use engaged discussions, focus groups, and lots of stakeholder surveys early on to look for themes for the impetus for change. In other words, we didn't want this to be about what do I think or the dean thinks are the reasons for change, but what do you think are the reasons for change? And then we fed that data back to them very explicitly in a series of communications and retreats to say, this is what you all are saying. It's not just us that think we need to move. So what did our team see? Well, the first thing is that medical education programs, what they responded to, are really structured in silos, and yet the development, we all agree, is longitudinal. So the architecture is a mismatch to what we think students' journey should be. This is a visual depiction of our architecture as it currently exists and is evolving. We have a series of sequences, meaning that we don't work in a semester-based system. Every student does one course at a time, organized by organ systems through the first 2 years. Our first year is all normal. Our second year is abnormal. Our third year, they move into clinical rotations. And our fourth year are electives and sub-Is and interviewing and vacation and then matching and graduating. Very similar structure to a number of other medical schools. The only deviation might be that some schools, like yourself, may be on a semester-based system, which is organized by disciplines as opposed by sequences or organ systems. But this has generally been the model that exists at many different medical schools for a while. But if you look at the model or the structure, there are definitely issues that our community brought to the forefront that we felt were really critical to address. One is the explosion of knowledge in the first 2 years. We've been packing it in for decades and not really deciding what is core, what is foundational, what needs to be removed, and what needs to be maybe repositioned elsewhere. The second is that as students move from the preclinical to the clinical years, even though there are heavy emphasis on systems and training in teams, our preclinical years wouldn't necessarily match that or prepare them for that particular journey. The third point was that our faculty were saying that while it's important to teach them science, where's the science in the clinical setting? how consistently are our clinical faculty actually bringing home the points that we taught in the first 2 years as it relates to an active patient where these mechanisms are being manifested? How are they being trained to think scientifically in the clinical setting? And part of the problem is that our students have been progressively marginalized in the clinical setting as well due to problems with their ability to document in the electronic health record, duty hours and the changes of teams and whether that relationship between the student, resident, attending, and patient is longitudinal. Patient throughput is much more frenetic and fast-paced now. So the students have felt farther and farther away from the core teams, especially in the inpatient setting, and it's even more challenging in the outpatient setting as well. And then finally, as we were thinking about our longitudinal development and what we think finishing school should be in the fourth year became so fragmented, and this has been written about pretty extensively, that the opportunities to develop leadership and leadership development were really lacking. And so we looked at the silos of medical education and said, this architecture doesn't support us being able to address all of these issues simultaneously. The second point that we came back to over and over again is that our assessment, what we communicate to our students as being critically important, was fairly inadequate and incomplete relative to what our physician professions were saying is important as students become residents and as patients require good patient care. So what do I mean by that? Well, we embarked on a process where we visualized all the assessment and tried to paint it across the spectrum of medical education. Here's UME, here's GME, which sometimes takes 3 to 7 years, here's more fellowship, and then here's even independent practice. And if you think about Miller's pyramid, which helps us think through where are we measuring and holding students accountable? Are we measuring what they know how to do, what they can show us what they do, and what they actually do? Where are we spending most of our time in providing real high-level assessment that can help students grow and communicates to them what's important? And when we looked at this, you can see that we're focusing so much on the lower levels, on assessing what they know, assessing whether they can apply it in a scenario. At some point, we sometimes start to say, can you do this in a clinical simulation lab? Can you do it with a standardized patient? And let's give you feedback that way. But even our schools and programs and our profession are really providing mostly assessment in the lower levels. So there's this disconnect. Nowhere, and so when there are studies that come out that show that this emphasis, for example, on step 1, which has become this gigantic pressure point for all of our students and our student affairs offices, that when you look at what does performance on step 1 relate to in the clinical setting, and the studies show that there really isn't much of a relationship. In other words, their clinical skills, their clinical practice doesn't relate to how well they did on step 1. That shouldn't surprise us. We really have this disconnect between what we are measuring and what we are stating is important and what we think is important for our students to do when they become practitioners. And then finally, the third point that we came to was really important for us at Michigan. Because we're a public university, we started asking the question of whether health outcomes that we see around us have any relationship to how we should redesign our medical education program. If health outcomes were acceptable or even exemplary, then you might state that, well, at least the existing system is actually working to some extent to produce those good outcomes. Our practitioners go out, they work in a system that provides optimal patient care, and our patient outcomes are actually doing rather well. But if we actually ask this question, we find different answers. This is the Organization for Economic Cooperation and Development's data, which comes out annually. It's an international organization, and you can see here that by every metric that we look at, nearly every metric, the United States as a country performs towards the bottom of the Western industrialized nations. So here's one of many diagrams I could show you. Percentage of our GDP on health expenditure and life expectancy. Here's where everyone clusters. And yes, there are countries that spend less and get low return. There are also countries that don't spend a lot and get very high return. Here's where the United States is, a very discrete outlier. And it's not the only graph I could show you. We're 18th worldwide in chronic disease outcomes. We're 15th worldwide in patient safety in our clinical environment. We're near the bottom in maternal mortality and infant mortality in the Western industrialized nations. Now, I'm not saying that education is solely the problem, but we must ask ourselves, what is the responsibility of us as stewards of the educational program to address these outcomes? In addition, we have to also look at where are we focusing our attention in education. This is really where the healthcare delivery system is moving all around us, that there is complex disease management that really physicians are playing the lead on. There's acute disease diagnosis and treatment that physicians and other health professionals are certainly playing a role here. But there's chronic disease management, which is really driving so much of the health outcomes, where physicians are part of an interprofessional team that is part of what they that really accomplishes the outcomes that we're looking for. I'm a primary care physician, and I am sometimes the least important member of my team as it relates to my patients when I work together with my pharmacist, my MAs, my nurses, my care management, my motivational interviewers that are part of my team. And then there's also the 80% of outcomes that are really not in our control: prevention, health maintenance, social determinants of health. And yet, when you look at where are our educational experiences in our curriculum, they are 80% here, focused on acute disease diagnosis and treatment. That is the hospital-based setting, and that is the hospital-based environment that our whole post-Flexnerian model was built upon. How much do we focus on chronic disease management? How much do we focus on the complexities of problem solving that are going to be required when we take care of patients with 5 comorbidities and 11 medications and try to figure out what's going on with them? Do we actually train our students in the sort of rational problem solving that's required to equip them for this silver tsunami that is upon us with older and older patients that they're going to need to care for? And so I would propose that the third most important problem is that we are not focusing, we're exclusively focusing in an area which may require us to broaden. And so all of these reasons actually came to transform, really came to the forefront for us while we were preparing for our LCME visit. And so our self-study period started in 2010 and it ended in 2012. And during that period, we actually had a fairly successful LCME study, but what we discovered is 2 things. Number one, we had a number of problems that were just described that we weren't addressing in our current model. Not that they would rise necessarily to the level of an LCME citation, but things that we felt were important that maybe the LCME wasn't focusing on. Number 2, we needed to build a much better quality improvement mechanism in our educational programs, where we were constantly looking and analyzing and improving each experience every year as things came up, driven by more than just student evaluation and student feedback, but driven by where we wanted to go. And we really didn't have that as robustly in 2010. But by 2012, we feel like we had a pretty good model, and we used that LCME to drive both those points home. So at the end of that, the dean then came to us and said, all right, now that the LCME is gone, let me come to your curriculum policy committee, and I'm going to give them a charge. And I'm going to state very clearly what I want that charge to be. So I'm going to show you what that was. The dean came in December of 2012, and he stated 2 things. Number 1, it is very clear that our system of healthcare is in need of major reforms and is continuing to reforms, and that these are not happening in isolation here in the healthcare systems, that the fire has spread to medical schools. So it's not just a nice to have to change. We are obligated to change to really address where the systems are going. And so what he asked us to do was to develop a new model. Develop a new model of a curriculum for medical students that would be then considered by the dean, the executive committee, and what we call the executive faculty, that would have the flexibility for our students to really start to handle this new core, but start to develop into these prototypic paths that would allow them to help address the needs of society. Our definition of executive faculty is anyone who's on faculty who's not emeritus. So at the University of Michigan Medical School, we have 2,800 executive faculty. And the reason why, as I'll get to, why it's important to pay attention to them is all of them are eligible to vote on any major change to our curriculum. And if they voted against it in opposition, then we wouldn't be able to change. And so this is a very fundamental fact. It's built into our regents' bylaws. It's because we're a public university, and the executive faculty does not delegate any authority to the dean or the executive committee to make that decision for them. It's the one thing they hold on to. So that's a challenge. We knew this though walking in. We walked into this eyes wide open. So we took the charge, but we didn't develop the model immediately. We really actually paused, and we used a year to really explore and develop a vision for this new curriculum. We understood why we needed to change, but what did we actually want to become? And who should be involved? What we elected to do was broadly engage leadership, educators, staff, and students to help us develop a new vision. And in essence, a new core. So rather than saying this is the model we want to go to and that's our vision, we stated that the graduate of the 21st century from the University of Michigan should be our new vision. And we spent 2 different retreats developing these concepts, and then we worked with a graphics artist to be able to present it in a visually appealing way, and then we went on the road and just started talking about this with the different departments. And people were a little bit impatient, if you will. They wanted to see what the model was going to look like, and we had to physically state, we're not there yet. We don't know what the model would look like unless we agree that these are the new core fundamental skills and attributes of the new graduate. At the center is that every graduate must be able to lead, meaning that they must be able to be an agent of change in whatever domain that they feel is important, whether it be at an individual level, a population level, a health system level, but that we should be equipping them with the skills to be able to be agents of change, built upon an outstanding foundation of knowledge and skills to be an excellent doctor. And these other dimensions, like creation and discovery, teamwork, lifelong learning, working with systems, and really engaging in patient care, were sort of part of that process, that were part of the vision, but at its centerpiece would be leadership and agents of change. And then again, rather than jumping to a specific model, a structure, we needed to understand what would be our approach. Did we want to use team-based learning? Did we want to use problem-based learning? There are a number of different pedagogical methods out there, and we analyzed them all and determined that rather than focus on a specific model for medical education, that we would be working that we would be focused on competency-based education, but that we would offer many choices to get to a competency-based model. We felt that the new approach had to be driven by the health needs of society, because that was what we were beholden to, and then translated into competencies of medical education, and then that would drive the model and drive the assessment system. And in other words, we needed to use that vision to define what our learners and graduates must do, and then design the system that would get us there. So this was the model that evolved after defining that vision and defining that approach, and built upon the rationale for change. This is a very high-level model that are addressing all of these different aspects, and it's visually depicted here. And what we realized very early on was that the current architecture could not work to help us achieve the new core. That having silo-based of 1 year of normal, 1 year of abnormal courses, followed by clerkships, followed by electives, was just not going to work in order to achieve this new vision. And so I'll take you briefly through this, and then I'll dive into some of the details during the rest of the talk for you to be able to kind of get a sense of what we're looking at. We're in Ann Arbor, so we thought that a tree analogy would be nice, since it's also called the City of Trees. So we focused on both a trunk and branches model. Now the trunk is basically an integrated approach to both science and clinical experiences, moving much of what is the clinical third year into the second year, but clearly connecting science to the clinical setting, both at a foundational level in the classrooms, and then also when they get into the clinical environment as well. With the focus not as much on what can you memorize and then regurgitate, but whether you've got a strong foundation of knowledge, whether you can apply it, and whether you can seek out answers to address what you don't know. Certainly still beholden to all of the USMLE Step 1 and Step 2s, but we felt that we could do both. That a lot of what the steps have been moving towards is applied knowledge in the clinical context, and that by bringing the clinical context earlier, we would actually be setting up our students for maybe even more success, because they would be seeing how knowledge is applied in the clinical setting more deliberately. After those 2 years, students then progress into one of many branches, professional development branches, which are aligned not with a department that they're interested in, but clusters of professional expectations within domains. And I'll explain what that is in a little bit. Advanced clinical learning experiences, and then learning how to think and teach scientifically, and then develop in depth their impact in the clinical setting. Overarching all of this is a program that we call our Paths of Excellence, which are scholarly concentrations that allow them to focus more in depth in an interdisciplinary topic that is related to medicine but not to their ultimate residency path. So something like global health, or bioethics, or quality and safety, or the scholarship of learning and teaching, that every student walks in with a passion or develops it, and then we would provide them the opportunity to dive in depth. And then overarching all of this is a new program that we started just a year ago, which is our new learning community. We didn't have longitudinal learning communities ever at the University of Michigan. We just started it a year ago. I know you all have had yours for quite some time now. But we felt that would be really important to be able to provide the mentored small group environment and longitudinal professional development through multiple of different courses that I'll explain in just a minute. We felt that there were many principles that could be addressed with this model, that we would be able to focus on the student as a master learner and thinker, that there would be more flexibility and the opportunity both to do things on core and then explore things in depth, that they could become leaders through a series of deliberate exercises, and then the connection of leadership in these different components, and that we would have assessment throughout all of these different components, not just those that occur in the classroom setting or in the clerkship setting, but that we would have rigorous assessment built on the vision for those things that we feel are important. In other words, we thought that this would be a liberating new architecture, and our hope was that that would be the case. So then we needed to really begin the design and implementation process here. And the faculty, what we ended up doing, rather than plunging into this massive project, as we often want to do in academia, we then again decided to step back and pause, even though the faculty really wanted to jump into this, and to decide how should we organize our curricular governance process going forward for the new curriculum. We had actually had a couple of pretty high-profile failures of curricular transformation in the previous 20 years that everyone knew about, and everyone walked in very skeptical to say, if you want to try something big, you're just going to flame out again. And part of the problem was also that I was in charge of one of those that had failed, and that I was also put in charge of this one to move forward. So people approached this with a healthy degree of skepticism, which was not unwarranted, given where we were before. So what we decided to do was actually turn to the business literature. I think in medical education we think we can do everything, and I think there's a lot that we can learn from other industries. And so corporations and business have really been looking at organizational transformation for some time now. And so what we did was we focused on 3 resources that I'll just throw up here. If anyone's ever interested in knowing the specifics, I'm happy to provide them. The first one is Bowman and Deal's Reframing Organization, which is actually one of the textbooks that I used at the University of Illinois in Chicago on health professions education. It's a fabulous textbook, but it encourages us to look at our organization openly through a series of 4 lenses. When we did this deliberate exercise, we found that there were many challenges to trying to move this forward from 2013 onwards. The first is that we were talking about something massive, probably a change that Michigan hadn't seen in at least 50 years, if not 100 years. So it wasn't an incremental change. The second is that we had had 2 previous successful curriculum revisions that were fairly incremental, but incredibly painful operationally. And people had a lot of memories of how difficult it was to embark on change. And as I mentioned, we also had 2 big failures. We had one where we actually in 1988 tried to go all into PBL. And it really failed after about 6 to 9 months. And we had to sort of back off on that. In 2008, we tried to do a competency-based education transformation. That was the one that I led that resulted in some new programs, but certainly not any kind of transformation, and then was shut down. So there was lots of institutional memory of that. The fourth is something that I think we all share, and that is that it's one thing to state in the dean's office that we would like to do something, but the real centers of power in medical education and medical schools reside in the departments and with the departmental chairs. They needed to be partners with us as opposed to recipients of change. And so we really needed to sit down and think through these concepts with them. They populated all of our work groups and our thinking groups as we started on this vision. We made that intentional decision because the central role of the department in the power structure is critical. And then finally, the vote, as I mentioned, was part of the med school bylaws, which we said, all right, rather than treat this like our current presidential candidates are treating it, we're going to use the vote as a surrogate for engagement. That if we felt that if we got as many people to work on this, even though people don't agree, that if they're working on this, that the proposal that would go before the faculty wouldn't be my proposal or my team of 20's proposal. It would be our proposal. And we're voting on our proposal as faculty members. That was the concept when we started this process. We also looked to Clay Christensen, who talked a lot about disruptive innovation. And when we analyzed what we were postulating, we absolutely thought what we were doing was disruptive. And so what we looked at was his model for how you set up governance or teams to actually focus and develop new innovations within an organization. And what it requires is an in-depth analysis of three things: your culture of innovation, your processes and procedures for curricular management and innovation, and your teams. Who are the people that you have around the table? So we had to do this rather painful exercise and series of exercises to look at all of this. What we felt is that we had a good culture of innovation, but it was mostly incremental. It wasn't on transformation. We had great processes and procedures for curricular government, but we had team members that were just tired of change and really very weary. And so what we realized that we needed to do is that we needed to bring more people on board and give them power. So we invited many people who were not part of the traditional architecture of educational leadership to sit side by side, and because of their perspectives, empowered them to make decisions and to try new things. But we also decided that we weren't going to spin this out into a separate organization. We were going to build this from within our CPC. So the ultimate structure ended up looking like this, where the Curriculum Policy Committee provided oversight to our steering and operations committees for this curricular transformation, with a series of work groups reporting directly to these steering committees. In other words, the CPC had to approve and provide deliberate oversight and get reports regularly from these different committees. But the CPC wasn't doing the work because it was just too much to maintain the current state and improve that while trying to think about a new state. It's just very difficult to do. In addition, what we did, and here we created a number of work groups. These are just 5 of them. We actually ended up having 11 different work groups focused on the different elements we were talking about. But we populated all of them with students. And our students really became a powerful ally for us. They weren't just part of providing feedback. They were actually part of shaping. They were colleagues and collaborators with us on this journey. They really did a spectacular job during our LCME site visit. The LCME site visitor said this was by far the best student engagement, student survey, student report that they had ever seen in their 20 years. This is Dan Hunt, who doesn't say a lot of things positively. So we took that as a strength that we could build upon. So we said, all right, next project, students, be part of the change process. And they've been phenomenal. They're part of every work group. They're on our steering and operations committee. And then they independently set up a student advisory committee to provide us kind of the crosstalk and the cross-communication to help us see and then respond to issues that are coming up, and then also to communicate out to the masses about the rationale behind why new things were happening. And as I'll show you in our timeline, the reason why this is important is that, again, we are not flipping the switch in 2016 to say this is when the new curriculum starts. We have been building new elements to the curriculum since 2013, and so students had to be part of that journey moving forward. This is their Student Advisory Committee website, and we have a number of different organizations. But they're not just recipients of the curriculum, they're here to help shape it. So from this high-level view, as we embarked on this, what that allowed us to do with that governance structure is start to design things in more detail. So this became this, with a lot more specific elements. And in our new model that we are already starting to put elements in, is that in that scientific trunk, that first year, we have a series of organ-based sequences, but rather than having normal presented separately from abnormal, we've created fused sequences, where in cardiovascular, for example, you will learn normal and abnormal physiology with all the disciplines threaded through simultaneously. Physiology, pharmacology, biochemistry, anatomy, embryology, all represented throughout those organ-based sequences. And that they will work on them in a deliberate way, and I'll show you even more detail as to what these courses are actually called. In addition, we created clinical. Remember that we also said that from the beginning there should be integration with the clinical setting or clinical problems. We created a course called the Chief Concern course, where students are deliberately working through chief concerns that patients may have within that clinical sequence, and working through the clinical reasoning process in small groups here. And then we also have created an evidence-based medicine type of course that then threads through, where they're learning how to ask questions and get answers from information resources to help answer those questions simultaneously. We created an initial clinical experience where students are assigned into clinical settings, not to learn clinical skills, but to observe how patients experience the health system, how systems work, and how interprofessional teams come together. And they get 2 of those sites longitudinally during the course of their first year. They then proceed into the clinical trunk, which is, as I mentioned, more of the clinical setting, the clinical experiences. The traditional clerkships moved early. And then, after completing step 1, they move into an 18-month phase of the branches, where there's more rigor and depth that I'll explain in just a minute. Longitudinally, we are creating leadership and paths of excellence activities and seminars throughout all 4 years, a 4-year doctoring course, and then the M-Home as the learning community really integrates the curriculum as they go forward. Again, I'll explain these, and these are all in very early stages, but I'll try and dive more in depth. As I mentioned, the trunk, this is the more detailed view of the scientific trunk. So these are our first 14 months, if you will, or 13 months is what it ends up being. It starts with a launch, which is kind of orientation, but with very deliberate activities. There are a few foundational courses that we put early on, molecular medicine, diagnostics and therapeutics, and also principles of ID and microimmunology. And then they move into the systems approach that then takes them past the summer break into a consolidative phase at the end of this process. So it really kind of ends after September, or sort of in the mid-September of their second year. And all of these threads then work through that entire process for the first 14 months, 13 to 14 months. The clinical trunk that they move into then starts with actually what we call a phase 1 of the clinical rotation. What we realized is what clinical clerkships frequently lack is an on-ramp of getting up to speed of how do you learn in the clinical setting. Many people do have boot camps or pre-clerkship type of experiences. We're designing this around organ systems where students will actually see patients in the morning but not be responsible for them. And then in the afternoon come together in groups and seminars and answer questions that they had based on what they experienced, learn how to present, but also learn how to go to the literature, do a write-up that is scientifically based, have graduate level seminars, and get didactics in the clinical context during that phase 1. And then they proceed into what are traditional departmentally based rotations for a 48-week period with a winter break in between, but all the while still having doctoring course. But our doctoring course is not in a separate small group. We're actually taking our doctoring faculty and parachuting them into the clinical setting to help students with their clinical skills while they are on their teams. So every student not only has their teaching attending or their ward attending who's responsible for clinical care, but they'll have a doctoring faculty who will help them with their preparation or their skills. If they're in a clinic, they're not only going to have their attending that's there or their resident that they're working with, but periodically the doctoring faculty will come in and watch them take a history or help them with a problem that they're encountering in the outpatient setting. So we're really trying to promote this longitudinal doctoring course to extend into the clinical setting. There's also going to be small group discussions that will happen quarterly as well as students start to debrief what's happening there. Then the students proceed into the branches, which is, as I mentioned, core activities that are clinical and have multiple different phases. We have 4 professional development branches that are here that we are designing. As I mentioned, they're not aligned with a specific residency program, but they're focused on a cluster of professions coming together. We have one being developed on patients and populations, which is outpatient chronic care, one focused on systems and hospital-based practice, one on procedures-based care, and one on diagnostic and therapeutic technologies. Now, within each of these, students aren't going to, they're not going to exclusively focus on one branch. Think of these as majors in an undergraduate institution that you have to actually sample and from each of them and then develop more in depth your expertise in a particular focus over an 18-month period. Because of the shifting of the calendar, we now give them 18 months to be able to provide, and already having finished the clerkships, to be able to dive in depth. And there are multiple different elements that are part of each branch. More clinical training, pursuing professional interests such as ties to leadership and paths of excellence, science learning integrated into those clinical rotations, and also an individualized learning plan and competency-based milestone-aligned assessments. Now, all of these are being piloted now because as it relates to when do we have to go completely live with our branches, it's not until 2018. So we've actually been piloting versions of these different elements within our M4 year that is gradually lengthening each year to then ultimately end up being 18 months long so that we can test out these models, see what works, see what doesn't. If you talk to the students, the most important thing they feel about the branches that they've come through already is that they have a mentor, an advisor, a coach, and an individualized development plan that's helping them achieve their goals and is holding them accountable to the things that they love. And so that part has probably been the most valuable part of the branches in addition to some of these other elements that we're talking about. It has 3 phases that we're envisioning. The first phase would be an area of discovery where they actually get more chances to explore in depth what they want to do. Right now, our model is that the students don't start until May before they have choice in what they might be thinking of if it's not part of the core 7 clerkships. Here, we're going to provide them, starting in November here, with far more opportunities to explore things in clinical elective blocks. And then there'll be a focus where they'll be diving more in depth in these clinical immersion blocks. And then there will be what we call finishing, where we have boot camps, where we have a number of different sort of advanced clinical rotations that they can work on. And opportunities, for example, to finish their paths of excellence in their capstone experiences. All the while, science is being integrated throughout. We don't have the right model yet, but we're piloting a number of different interesting experiments where they move from not only discovering science and applying it, but starting to learn how to teach science. Because as our students become residents, all of our students will become teachers. So we felt this would be a great area for them to get deliberate training in doing that. And so we're trying these in different pilot activities to move forward. And remembering that the trunk and branches is really this, the foundation, we also have these other 3 strategic pillars which are part of our core program. Not elective programs, but part of our core program. As I mentioned, leadership, paths, and our community are really key elements. So our leadership development program, as I mentioned, lasts over 4 years and is really not a separate course, but is viewed through the lens of each of the different components of the program. Because what we do is we focus on 4 competencies. And we say that leadership is not a title. It's about being able to communicate and influence at multiple levels. It's about being able to work in teams, whether they're homogeneous or interprofessional. It's being able to understand and also manipulate systems, and then also to solve problems. So our students get a series of exercises integrated throughout the 4 years in the idealized model with a portfolio that they'll start to populate, which shows what is their leadership development. We firmly believe that the students' leadership paths are going to be different. There are going to be 170 different paths for each class. But if they're focusing on these 4 competencies, we think that that will help propel them in a way that they may not have been able to do before. Our Paths of Excellence program, as I mentioned, has multiple different aspects to it. These are our scholarly concentrations. These are the 8 of them that we have been piloting over the past 4 years and are now fully launched and active. Global Health and Disparities, Bioethics, you see the names of the different ones that are up here. Each of them have teams of faculty that are part of it. Each of them have a connection to a different center on campus. So we use this as an opportunity to connect to the rest of the university. So for example, our Health Economics and Policy has a direct relationship to the Gerald Ford School of Public Policy. Our Medical Humanities has a direct connection to our LS&A, our Literature, Science, and Arts program, with a number of faculty helping to co-lead, if you will, that particular path. In each path, a student has mentors, advisors, a community. They really get to pursue something that they're passionate about in depth. Right now, it's elective. We have stated very clearly that in 2 years, we're going to make it mandatory, But there's so many different logistical hurdles to get there that we're worried about that as a possibility. But even though it's elective this year, 140 out of our 170 students applied for one of these 8 different paths. So the interest is definitely there. We'll have to see whether how do we scale it? How do we accommodate that huge volume? It's definitely a challenge. And then our third theme is something that you all are also familiar with, and that is our longitudinal learning community. We call it the M-Home. Everything has to have an M at Michigan so that we can put the brand somewhere. But the M-Home our M-Home has 2 discrete purposes. First is that it brings the curriculum together, and we do house our doctoring course within the M-Home, the 4-year doctoring course. So we have faculty that are doctoring faculty that follow our students longitudinally over 4 years in small group setting. One of them is instructional, the other one is a coach, and they're within the 4 discrete houses for our students. And it's also places where the other curriculum can come together. That's our ultimate goal. We haven't achieved that yet, but our hope is that we'll start to integrate these different points going forward. And then the second is that it becomes this community where they connect to each other, to two different faculty across houses, that they actually develop ideas and constructs to support their own wellness and professional development as well. So with these 2 components, it's really been a critical, important step for us as the third strategic pillar going forward. So it's really important, I think, to just understand that what I presented appeared serial, like we did this all in a lockstep, but it actually was very chaotic. And we started piloting things very early, even before we had put the vision in place. And that was something that we intentionally did, because it is impossible to really convince or to try and engage the community without real experiments and real experiences. We were talking a lot of theory, but most of the time I felt like I was not connecting with others because they couldn't really understand what we were talking about, and honestly, I couldn't give examples of what we were talking about or what we were envisioning. How are you envisioning science being taught in the clinical setting? That seems crazy. I can't even envision that as a basic scientist. And I completely understood that perspective. So what we needed to do was experiments. We needed to do pilots, new courses, new programs all along the way, and be able to understand what we were talking about and look at things authentically and say, this was an interesting idea, but just cannot be scaled. So therefore, we need to think about another idea. This was part of the model, but maybe the model should evolve because that idea didn't seem to be practical or didn't have the impact we thought it would. We were fully open to that particular prospect. And we actually learned this from analyzing the third business case that we talked about, and that is John Kotter's 8 steps to organizational change. These are the 8 steps he talks about. This reflects our analysis of what we've been doing for each of those 8 steps. I'm not going to go through it. But in one of them, he talks about planning for and talking about short-term wins. And this is really where we talked about piloting in multiple different venues. So we did lots of programming, lots of pilot programs, working with a number of different organizations. We anticipated all of them could be part of our ultimate curriculum. In leadership, in our paths of excellence, in the trunk, in the branches, in our doctoring course, we worked with a lot of programs. Some of these have found their way into the curriculum, some of them have not. We also started piloting paths, really from the beginning. From 2012 is when we launched our first path, and then we built to get to the 8 that we have right now as being a vehicle for impact. But we needed to see what worked, what were the scaling problems all along the way. And then finally, we needed to do pilot courses and pilot sequences. We could not just flip the switch on this and expect us to move from an 18-month basic science model to a 13-month model, move all the clerkships in without trying a single thing. What does a fused sequence look like when our entire culture has been built on doing normal in the M1 year and abnormal in the M2 year? So we did lots of pilots and new courses on leadership. We created our doctoring course and launched it before we even changed the architecture of the curriculum. We created new interprofessional courses on clinical decision-making. Newton mentioned our $6 million grant that the university partially funded to create a new center for IPE. This was a course that emanated from it that our students are now participating in it. We created a new health policy MOOC, a massively open online course that our students across campus take, not just the medical students, but the dental students, the pharmacy students, the social work students also take. We started to fuse organ-based sequences. So we created this year and piloted a sequence that we envision will be part of the new model in musculoskeletal education and in GI. And both of them were fused in slightly different ways, and we're learning what worked. And honestly, there were some things that worked extraordinarily well and things that worked pretty poorly. But we're using that. I don't think learning really suffered because their performance seemed to be fine. But when we looked at sort of operationally and what made sense pedagogically, some things were good, some things were not. And we're using those lessons now to scale up to the new model for 13 months of fused sequence that will start this coming year. We also have new clinical reasoning courses, a chief concern course that we started before the new structure started, and we created a new hands-on clinical reasoning course in the ER, where students in the first and second years are actually in the ER, encountering patients, but just working on the differential diagnosis with individual instructors. And lots of new assessments. My assessment director and my assessment dean talks about the fact that what she wants to create is 1,000 points of light. That rather than those discrete arrows that you saw before, that students should get tons of data about how they're doing, some of which are high stakes, some of which are low stakes, but that we should be creating multiple different assessments to match to the particular vision in order for this to move forward. So with all of that, then we felt that allowed us to move into the vote. And the goal, as I mentioned, was to vote for the vision, the direction, the team, and a commitment to iteration, meaning that the model could change. We're not promising you that what you're voting on now is exactly the way that it's going to be in the future. And the result of that vote was that we had actually the largest turnout ever in a medical school faculty vote. As you can imagine, we have 2,800 faculty, so this turnout doesn't look that great, but in general, about 200 to 250 faculty vote on anything, like a new department, new bylaws, previous curriculum revisions. In this case, 762 faculty voted, which was an enormous turnout. And out of them, 80% of them voted in favor of this proposal. And I don't think they were voting for a particular sequence or a particular course. I think they were voting for this direction and the fact that we felt that this may change, but that we will try to do our best moving forward, and that they were part of receiving the information on how we were modifying things. And as we entered this phase, we realized that we were not at the end, or the beginning of the end, but probably the end of the beginning. And that's definitely true, because what we realize now is that we are truly now into the most difficult aspect of change, and that is implementing it. And the challenges that we have ahead are probably the same challenges you face. Defining what is foundational, engaging science in the clinical context. How do we value education and reward faculty for the teaching that they're going to do? How are we going to train them? How do we balance this concept of differentiation and flexibility with defining what is core for all students? We're really sort of walking that navigation very carefully. And what kind of system are we going to set up for assessment? And then honestly, the biggest challenge I see is how do we continue to innovate? When we move into this phase of operations, it is very much a tendency among everyone, myself included, to just focus on doing the work. But how do we continue to stretch ourselves and experiment in areas because we don't have the answers for all of these particular questions? And how do we continue to do that? I think those will be the biggest challenges that we face going forward. So I thank you for your attention. If you are interested in even more of these details, believe me, we've got everything on our website to your heart's content. This is our curriculum website if you're interested, and please feel free to wander there and learn as much as you can. And I thank you for your attention. I'm happy to answer questions. Yes.
I have something. One of the challenges that we face from an interprofessional point of view is that it's tough to find interprofessional experiences in a clinical setting. That so much of healthcare is, delivered in teams. They're not teams that you would call organized teams that are on the field at the same time. They're kind of hit and miss teams. So how do you kind of overcome that barrier? Or do you have any plans to overcome it?
Yeah, I think it's more on the plan side, because I think that's really critical. What we found was that as we started this center, all the other schools were focused on building more courses. And we were much more interested in finding these experiences. And so part of the challenge was us getting them to realize that that will be really even more challenging and important to do. So part of it was an awareness. But we've actually thought about 3 possibilities, and none of them have been ramped up yet, but there are a few possibilities. Number 1, our ICE experience, where we have our medical students in those settings learning from other health professionals, and it goes every other week for a semester. We're actually engaging other professional students to be paired with our medical students in those settings so they can see how healthcare is delivered.
In the first year?
In the first year, yeah, that we're starting that. And we don't know how it's going to go, but we're trying to kind of do some outreach there. The second is our student-run free clinic. So our student-run free clinic is really been run by our medical students, created by our medical students, and now it has become an interprofessional health organization where they've now partnered with students from the School of Social Work, Pharmacy, and the goal is for them to also be part of the leadership team where care can come together with supervision of different interprofessional faculty in that particular setting. So we're trying something there as well. The third thing is whether we can learn from the GME side. And that's something that we've started to think about. We don't know if that will be helpful or not, but since residents are pretty much always in the clinical setting, we're looking for where our residents are, where interprofessional care happens, and then seeing whether we can start adding our students more deliberately into those settings with other health professional students. But we haven't gotten there yet.
It's mostly just been in rehab, which is nice, but
Yes,
limited.
right.
You know, so orthopedic services or
Right.
official rehab have always been interprofessional.
Very interprofessional.
But the rest of delivery is nominally, interprofessional. I mean, they interact, but not, in kind of a tag team type fashion.
Well, I've been surprised when I've asked that question as to some of the things that we've uncovered that we didn't realize was actually kind of like the rehab example you give. So, for example, when I asked this question at our last steering committee, people started talking about tumor board as a real interprofessional experience with multiple different, not just physicians, but non-physicians participating. A second person talked about just some of our primary care clinics actually have had some organization around patient-aligned care teams in our VA, where they actually have pharmacists, social workers, mental health providers, and primary care physicians and nurses huddling and doing team-based care regularly on a half-day basis. Students aren't anywhere in these settings. So part of it is kind of just cataloging, maybe asking the question and then saying, are there students there? And if not, what would it take maybe to get a student there? We have not done the second 2 steps, but that's our goal, is to start doing that. It's a great question, though. Yes?
This is very intense from a clinical faculty standpoint, especially if you're going to start talking about mentoring 170 students individually. So how do you plan on getting your University of Michigan faculty to carve out the time to be able to do that?
It's a really important question. So I don't think this comes without some modicum of resource investment from the dean's office. So there has to be some sort of investment. We have a model where faculty are compensated for their teaching and mentoring and advising in 2 different ways. One way is through tuition recapture that comes through my office from Central Campus to my office that then I feed to the departments based on the logging of activity that their faculty do with my staff on the teaching intensity that they do. The second is I also provide direct offsets from my office for some of the coaching and advising and small group work that some faculty do. So if I state that I expect 0.20 FTE to be committed to this, then there's 20% of that faculty salary that goes from my office to the department in that faculty member's name so that the chair can create the space. We needed to do that in order to allow faculty that time. We've actually been doing that model for about 15 years now, and it has helped to engage the faculty. Because at the end of the day, getting back to that 4th bullet, the departments are the center of power here, and they have to make their faculty whole. They're responsible to the dean, and if we say this is going to require that kind of effort, the chair can say, that's great, but you're still holding me responsible to their 100% clinical effort, or their balance of clinical and research. Where is the offset to allow me to give this faculty member the space to be able to shrink their clinic or reduce their research obligations? So we had to do that about 15 years ago. It's not without investment, and it's certainly not without conflict.
How many dollars are you talking about?
My budget for the two phases combined is about $33 million a year. So it's a lot. I will say from the standpoint of small group facilitation, it's probably $3 to $4 million out of that. It's a pretty sizable chunk of my budget. And every school is going to be different. I think part of I do think though that faculty, their reluctance is dependent on whether they can fit it into their incredibly busy life. And if there isn't some degree of resource allocation, I think it's hard for them to justify participating as passionate as they are.
Related to that, we've had a problem that many schools have faced about how to incorporate like outpatient practitioners. To use an example, my wife's a busy internist as a geriatrician.
Yep.
She's not involved in educating students in any way, nor are any of our partners. But it doesn't seem like we have a good model to answer Mike's question of how, because she's treating the chronic diseases, she's doing the kind of team-based approach that would be in a sense, the ideal faculty member, but we can't reach out in any real way because just the sort of the dilemma. Well, I'm not doing it for free, but we don't have a clear way of compensating and engaging that group, not just my wife, but that whole group of busy outpatient practitioners that don't have residents standing next to them. How is it to engage that group?
It's quite challenging. I will say that there are models out there to start thinking about, and we're starting to think about this as well, in the outpatient setting specifically. The first is, the key challenge is that students often will slow practitioners down in the clinical setting.
Education takes
It's inevitable. Absolutely. But there are creative ways actually to create schedules where that may not happen, that have been starting to, I don't know that they've been published, but that we're exploring and piloting in different settings where you can, it does require some resources at some point, some degree of forgiveness to allow faculty to be able to engage a student. So there may be some creative scheduling. The second thing that I think is a good way to get started that we're also starting is we're asking our first year faculty, the faculty who have students in their clinical setting for the ICE program, to start identifying what are opportunities that you think students could add meaning or do work in that clinical setting that they could both learn from and also not slow you down. Maybe do something that other members of your team are doing or that they could be trained to do. Some of the ideas that have come forward from there have included medication reconciliation, motivational interviewing, patient navigation, and then also while they are there, they're actually serving some role, which I think students want to feel that they're not just a shadow. They actually want to be, have a meaningful role. Yes. You just don't want to be a shadow. Absolutely. But then it engages the faculty because they say, well, that student's actually contributing to the clinic as well, and they feel more engaged to help teach or to help show them and incorporate them into clinic. So that is a question that we're just starting to ask. There's some great models out there to look at. Penn State has a great model on the patient navigator, student as patient navigator, that may be interesting to think about. And I know that Mayo has also looked at how students can be integrated into the outpatient setting in a way that doesn't affect productivity. So there may be some models. I don't know if they're published. I think some of them have been published. I think Penn State's new one just came out in academic medicine a couple of months ago. But I think people are starting to wrestle with exactly the same question you're asking.
Thank you. And Dr. Mangrulkar is in campus for a little bit, so if people want to talk to him more, we can arrange that. But thank you so much.
Absolutely. I'm happy to stay as long as you want. Thank you, Jan.